The case actually is an interesting case. I work in a large center that has the advantage and the disadvantage of having a very large heart failure service. And as a result, we happen to see a lot of patients who have had transplant or are being considered for transplant or unfortunately have other therapies that they've been submitted to. So this is a case that is off-label, so just as my disclaimer. So this is a case of a 48-year-old woman who has had pericardium cardiomyopathy after her third child. And in November of 2014, she actually had a HeartMate 2 as a bridge to transplant. And 4 years later, she was still doing relatively well, and she was being evaluated for transplant once again. However, it was noted that as her EF had continued to decrease, she had significant aortic insufficiency. And once again, as a transplant workup was being performed, it was noted that she had a very reactive cytoscreen. So we met her in the ICU. Her 3 children were there. She was a fairly active individual, somebody who really wanted to go above and beyond the call of duty. So we really took a lot of effort in trying to make her better. She was in shock when we saw her. She had been developing acute kidney injury and acute liver injury. Her INR was now greater than 9, and she was requiring increasing amount of hemodynamic support. This is what her echo looked like, and as you saw, her ejection fraction was very much diminished, and she had a continuous torrential aortic insufficiency. So the amount of output from the LVAD that was basically circulating had been worsening over the significant amount of time. So we all sat down around the table and tried to decide if we're going to offer surgical valve replacement. The transplant service had decided that she was not going to be a transplant candidate in her current state. They were not going to take her to the operating room to try to do surgical valve replacement or aortic valve closure. And then potentially the ball was sent to us either to use a amplatz scribiform device or potentially a transcatheter valve replacement for the treatment of aortic insufficiency. Somehow we decided that we were going to do transcatheter valve replacement, and that's basically what we're going to be talking about. The problem was that, one, we didn't have a CT scan. So with the management or the magical hands of our cardiographers, we were able to devise that potentially at the level of the annulus, the perimeter was somewhere around 85 millimeters. However, immediately underneath the annulus, the LVOT just funneled out like a complete circle, and it was almost close to 95 to 98 millimeters, which posed an important limitation. The other thing that we were obviously very much aware was that there was no aortic insufficiency. There was a fair amount of aortic insufficiency with no aortic calcification. So as a result, in order to guide the procedure, we decided that we were going to use 2 pigtails to mark where the annulus was, and we're going to basically go ahead and try to place a 34 evolutar, as we had attempted to oversize it as much as possible to try to gain both the annulus and the LVOT. We had a large discussion with anesthesia and the transplant service. Everybody was in the room getting very, very excited, or not.
Excited good or excited bad?
Excited.
Excited.
So this was one of our first cases that we had done a valve for AI, and we figured that we were going to decrease the RPM of the LVAD in order to minimize the sucking effect, quote unquote, of the device and slowly attempt to deploy it. So we decreased the LVAD to 7,000 RPMs, and we started deploying in what we thought was relatively well, and the valve immediately just went down. And the patient tolerated well the first time, and then we decided that we're going to go back and do it a second time, and the patient did okay the second time. But by the time the third time came along, her right atrial pressure now pretty much increased to the mid-30s. Her systolic pressure dropped to 50s. Her PA pressures were now greater than 70s, and her mixed venous sat was down to 30%. So by that time, the transplant surgeons were not very happy, and were actually about to place her on ECMO or something of that nature. So we increased the RPMs one more time, and we figured that this time around, we were just going to do it at a normal speed. So either we were lucky or everybody provided the right amount of traction, but we finally were able actually to land the valve well and deployed it for at least at the 80% level. And immediately as we did that, the SVO2 increased to 60%. And as you can see here, there was just a trace amount of aortic insufficiency still when we were not fully expanded. We went ahead and deployed it completely, and this is what our end result looked like. The valve was fine, and it actually stayed in place. And actually, the patient went home 3 or 4 days later, immediately came off of all of the inotropes, and that was incredibly satisfying, particularly when we were able to tell that to the family. So she did go home, and we saw her in follow-up actually 6 months ago, 6 weeks ago, and she was doing very well so far, still in the process of being evaluated for a transplant TAVR. So the treatment of LVAD-associated AI is difficult, and I think there's many options out there. TAVR may be a reasonable option in selected cases. You definitely have to oversize the prosthesis. However, how much of it, we don't really know yet. And then anchoring the device is limited due to the absence of calcification, annular dilatation, and the LVOT widening. But importantly, we learned that altering the function of the LVAD during the procedure may limit the migration, but definitely may create hemodynamic instability. So by a rule now, we actually don't do that. And so far, we've had actually much easier and or better results.
That's great. This is one that's tough. I mean, last year I showed a case of an LVAD that we actually put 4 valves in because it's so difficult. That was with the legacy core valve. So what was so amazing with this case is that the evolute seemed as if you had better repositionability and you had more control. The other thing that we've sometimes done with these AR cases is actually pace fast, almost pace like sapien pacing when we're trying to deploy it, just to make sure that it stays in place. Because you've outlined the fact that if you go slower with that and you're not in the right place and it's actually going to the ventricle. I think it's a fabulous case. Very, very nice. Any other comments? How many have done a case like this where they're tough, right?
Sometimes you can go with the carotid hangs off of there. A lot of these heart failure people have big vessels, and it's not a real threat, and so you don't have to worry about that energy loss in the arch. It's just hanging on a stick.
Yeah.
That'll make it a little easier.
And that's actually what we did. For the final deployment, we had the person up front was definitely, position 1 was pulling hard, and actually was able to maintain it in place as everybody else was being able to deploy it.
Yeah, good. All right, that's great.
Thanks.
Perfect. Thanks.